It is my pleasure to introduce our presenter today, Dr. Lauren Hyer, who I've presented several years. She is a regular here with AMCSI, and recently this year, AMCSI and her hospital, Shriners in Greenville, partnered and did a 2 day, right? One day, 2 day
For
for the
camp,
yeah
5 day.
a 5 day camp, but the 1 day informational
Oh,
family AMC
yeah. We have like a
meetup.
mini
We
meetup.
do a
Yeah.
lot. It's cool. This is one of our favorite hospitals. So she will be presenting today about the treatment of feet in children with AMC. Please join me in welcoming Dr. Hyer to the 2024 AMCSI conference.
Right. Okay. Oh, I guess I need to turn this on. That would be helpful. All right, now can people? There we go. Okay, perfect. All right. Well, once again, thank you. That's not going to work.
There we go.
Okay. Maybe if I walk away from that, is that too close? All right, I think maybe it's okay. I just got to stand in the right spot. Maybe if I need to go back here. Okay. Hi.
So you're from Greenville?
Yes, ma'am.
Okay. Jennifer Taylor is coming on Saturday.
Oh, okay.
Oh.
Yeah, we're starting our presentation. Can I catch up with you? That's okay. Yeah. All right. But I'll catch you right after we're finished. Okay. All right. Okay, we're moving on. Let's talk about feet. So we're gonna kind of just run through real quickly, like what Shriners is, what arthrogryposis is, kind of our Greenville method, how we approach care to the child with arthrogryposis, and then we'll talk about feet from babies to skeletal maturity. So we have a lot to get through. But if at any point, if anybody has any questions, please feel free to raise your hand. I'll be happy to make this more interactive as we go along. So let's jump in. So Shriners Children's is a healthcare system that was founded 100 years ago. We have sites all over the U.S., Canada, and in Mexico. We do mostly orthopedic care, but we also have some sister sites that do burn and spinal cord injury. We have a 3-part mission, which includes patient care, clinical research, and then educating the next generation of medical providers. I think what stands out about our mission as opposed to most of healthcare in the United States is that we're able to take care of children regardless of ability to pay, and we're able to take care of these kids from birth until 18, sometimes till 21, but we don't really advertise that too heavily. So, okay, so a little bit about Shriners in Greenville. We have several. What's really nice for a family of a child with arthrogryposis or cerebral palsy or any other long-term pediatric orthopedic condition is that we're able to offer our outpatient services, PT and OT, prosthetics, orthotics, and surgery all under one roof. What makes our hospital stand out as opposed to some of our sister institutions is that we also have a motion lab. We do all of these interventions. What's the purpose? Let's hope that we're getting you to walk and have better overall mobility. So we sat down a couple of years ago to try to put some words to like what is our mission? What are we trying to accomplish with every child with arthrogryposis that walks through the door? And to summarize, we are partnering with families to promote mobility and advance each child to their highest level of functional freedom. So that just is, if we had to put it in a nutshell, that's what we're after with each child that walks through our doors. Some of our principles that we try to focus on when we're thinking about functional freedom, it's really easy, and I'm going to be talking just about feet, but I can't talk about feet without looking at a knee and a hip and looking at the child as a whole. No child presents to my clinic without parents and without a social context into which they've been born, and those are all things that we have to take into account. Then when we get down to the nitty gritty, we focus more on like, can they do something and more efficiently, and how they do it is really of secondary importance to us. I was just talking with Alexis up here, we really embrace a both and strategy. I love what one of our OT says, that she's like, I could ride my bicycle to the grocery store to get groceries, but I don't. And so we really embrace, like, we love walking. We love our braces that help us to walk. But sometimes it's better to just have overall efficiency and embrace a wheelchair. We don't consider that a failure. We consider that being smart. And then kind of our last 2 things is that we really focus on individualizing a plan to each child. There's no one size fits all approach for these kids. Everybody has different shapes and sizes and comes to us with different levels of contractures, and we have to manage each plan individually. I will say our baseline goal though is a standing transfer. I think if you could do a standing transfer, that allows you potentially to live a more independent and functionally free life. So that's kind of our baseline goal. Everything else we still push for, but that's kind of what we're after. I love what one of our PTs said long ago, that really this is a three-legged stool, and thankfully at Shriners we have those three legs in place. But if any one of them is weak, the stool topples over. So really, kind of if you had to boil it down, yes, genetics and nutrition, all those things are very important. But if you have to boil it down to like functional freedom, we need PT and OT, we need good orthotics, occasionally prosthetics, and then we need good orthopedic surgery. And so if any of those are out of sync or not up to strength, the stool topples over. And so, but then at the center of our team approach is of course our family. Again, no child shows up to my door without an adult, and so we have to certainly keep our family at our center of our focus. All right, so that's a bit about Shriners, a bit about our Greenville approach. I'm happy to talk more about that, but I was given the topic of feet. Everybody's favorite. I will say I wash my hands a lot at the end of clinic because I touch so many feet. But again, kind of just in keeping a one size does not fit all approach. What are our goals? You probably have heard VB or other folks say, like, really our goal is not like the perfect, most aesthetic foot. Our goal is a very functional foot, a foot that can get flat on the ground, that can fit into a shoe and or a brace, and that hopefully is pain-free. And then what I really try to aim for is I would love for this to be a reasonable amount of intervention. I sure would love it if I got to meet every AMC baby when they're 5 days old and cast them and they have perfect feet the rest of their life. It's just not the case, but we do just try to be reasonable with the number of interventions that we put these kids through. So disclaimer, I'm going to discuss most known strategies. Some strategies I'm a fan of. One or two of these strategies, maybe you will or will not be able to tell, are ones that I just, I don't personally embrace or do very often. But again, we're going to individualize this treatment. There's going to be some common themes, but of course, with each patient's unique circumstances, we may have a unique plan. So if you're a parent of a child with arthrogryposis, you may have had an ultrasound that looked something like this, and the ultrasound tech is like, ooh, those feet look different. They may or may not have shipped you off to the maternal fetal medicine specialist. But as we learned in a previous presentation, only about 50% of kids are diagnosed in utero, so maybe not. But we at Greenville, man, we love babies. I know we have June and Kyler. Sorry to call y'all out. Running around here, and they're just, there's just something extra special. I as a mom, I just love babies, but there's just something extra special about a baby with arthrogryposis. But what we really love and what our therapists really love is this is the golden window where our therapists get to shine, where we can actually improve range of motion and potentially change the trajectory of this child's life. That golden window is like 3, 4, 5 months. And so when I hear like, oh, there's a 2-month-old out there, I'm like, get them in fast, like drop everything, cancel, other patients, let's move, rearrange, let's get these kids in. Because the contractures are worse at their birth, but most responsive to conservative management, and when we all love to avoid trips to the OR. Okay, so feet. So nearly 100%, or definitely in the high 90s of patients with arthrogryposis are affected in their feet. Even if you have the most mild of distal arthrogryposis, just kind of by definition, you're probably affected in your feet. So I think this is something that almost universally ties the AMC community together. Feet typically come in 2 flavors. By and large, the majority of them are this top one, the clubfoot. There is kind of a variant of that clubfoot described by Dr. VB called the equinocavus foot, which has just is almost like a milder version of the AMC clubfoot with some slight differences in treatment. And then another 20% have this congenital vertical talus. And so let's jump into what that is. That's what the equinocavus foot looks like, and the congenital vertical talus, that rocker bottom deformity. Okay, so I think it's really important just for families to know what a clubfoot is, and let's break it down to how we as orthopedists think about it. We have an acronym. We love acronyms, and so this one for clubfoot is CAVE. So let's start cavus. That means you have a high arch, that nice crease in the bottom of the foot. Adductus means it looks like a kidney bean. It's curving off to the side, pointing inward. Varus means that the heel rolls under, and equinus is a Latin word for horse, and it means that the heel cord is tight and the foot is pointing down. So how do we treat it? Without intervention, very disabling. So we do get some kids that are adopted at a little bit older age and have had no treatment or minimal treatment, and they're walking on the sides of their foot. Not a sustainable gait pattern, guaranteed to cause pain in the adult years. We used to, I'll skip over that slide real quickly, but we used to say, oh, nice to meet you. Let's just grow you till you're like 2 or 3 and do a huge surgical intervention. So if you come to us early, that's not usually the case. Sometimes our later kids, we have to jump to that, and we'll get to that in the next kind of subset of age. But the new standard of care, whether you have what's called an idiopathic clubfoot and you don't have contractures anywhere else, or you have arthrogryposis, we start with Ponseti casting. So this is Ignacio Ponseti. He was from Spain, moved to Iowa, and really revolutionized clubfoot care, not just for our AMC, but for the idiopathic clubfoot. So what is it? 2 parts. Part 1, obtaining correction with a series of casts, which looks something like this. We usually conclude that casting with what's called a little tiny procedure that in a nice sleepy child who's not going to kick me too hard, we can usually just put some numbing medicine in. I tell them it's no worse than a little boy having a circumcision or a little girl getting their ears pierced. This is nice, quick, easy. We can typically do it in an awake child if they're not too old or feisty or strong. And then we move to part 2. Let's segue into the equino cavus deformity. It's basically the same management. It's just putting the pressure points a little different. The equino cavus foot doesn't have that varus component, so you don't need to be rotating that foot out as much. You need to focus on rotating the foot up, and we can do that with this 4-finger modified technique. But then part 2 is maintaining that correction and preventing recurrence. And so in our idiopathic kids, we're doing this with that boot and bar. Most of our AMC kids, because they oftentimes don't have a good kick, we need to use something more custom to them. Sometimes we put these braces into these braces, and there's just a lot of bracing going on. But what I will say is that we're probably in some form of an AFO at least at nighttime until the child's done growing. So outcomes, several different pretty decent studies. I think the summary is that Ponseti method works for initial correction by and large. Let's get into things to be aware of. The theme of whether you're talking about hips, knees, or feet is recurrence. While that baby who's born their contractures are worse, you can stretch them out. They always want to go back to that position that they were born in. And so recurrence is our nemesis. How do we stall this out? This is where you guys are involved. I can't go home with you and continue to cast your child for months and months and months. We need to be very compliant with our braces. We can learn what's called the French method of stretching. One of our therapists is certified in that. And I think it's really, this is empowering to you guys. Not to say that like if we suffer recurrence, it's a failure. It just means that like we can potentially like intervene. You guys can intervene. You guys can take control of this. And we can at least like prolong the time between recurrences. Ambulation is something that can help decrease recurrence. And then finally, when our kids are done growing, then we can stop worrying about recurrence. So why, like my friend who has an idiopathic clubfoot, they're done, like they were done with braces when they were 3 or 4. Why with AMC? Well, what I tell families is that the bones are dumb and they have growth plates and they just keep growing and growing. That your skeleton doesn't know that the human it's occupying has arthrogryposis, and so the bones keep growing. Well, these muscles that connect from all the way from the knee all the way down to the ankle in arthrogryposis are really stiff and fibrotic, and they don't get the same amount of stretch that a typical child gets just by running and playing. And so when you have a tight steel cord in the back of the ankle and the ankle is growing, well, guess what? Then it recurs. And so that's where it's really important that that our team and then the family just partners together to try to provide that optimal stretch that a child with arthrogryposis may not be able to do on their own. Let's talk about some other things to be aware of. We do a ton of casting. I think sometimes I get a parent and they're like, this baby's just not loving this cast, and why? Well, maybe the baby can't tell you that, hey, doc, every time you push right here, you're actually pushing on my nerve. And so I think it's just something to be aware of, something that's like, oh, it's just a cast. These babies do have normal sensation and can feel, and sometimes it can be uncomfortable. X-rays are almost always worse than the clinical appearance, so we treat the patient and not the X-ray until the patient needs more intervention. Pressure sores, casts are not a perfect science. And then stubborn feet. I'll take a moment just to talk about this Mosca approach. Vince Mosca is a pretty famous pediatric orthopedist in the Seattle area, on the brink of retirement, or may have just retired. But he has done a world of work in the clubfoot arena, especially for idiopathic clubfoot. But described this approach where you have just a really stubborn foot not responding to cast. You can kind of do what's called an extra articular release, where you just do like these little tiny surgeries. What it does is it unlocks the door and then allows casting to actually work. So that's kind of, sometimes if you get a really stubborn foot, we'll take this a little bit circuitous route to try to get the foot in an improved position. You can see after that surgery, it allowed the foot to cast and get into an improved position. And then last thing, AMC toenail. I think the foot was never designed to be in a cast and a brace for forever and ever. And so I don't know, almost all of my kids have toenails that look like this, and I'm really sorry, I'm not very good at managing those. Just trim it the best you can. Occasionally we'll take them off in the OR if we need to, but just something to be aware of. I think, you guys deserve to know like what you're up against. So, okay, let's switch. So now we need to kind of really like turn almost 180 degrees. We're going to talk about congenital vertical talus, which is nearly the exact opposite deformity as a clubfoot. And why do we call it congenital vertical talus? Well, you can see here on this middle picture here, this bone is called the talus, and it's pointing straight up and down. And then when we try to push the foot down, it's still pointing straight up and down, and it doesn't reduce. So it's basically a midfoot dislocation. So again, old standard of care. Nice to meet you. When you're like 2 or 3, we'll do a big surgery on you, and sometimes we still have to, but that's not our first line intervention. There is a physician who's now with the Paley Institute named Matt Dobbs, who in the mid 2000s developed the reverse Ponseti technique. And so basically it's the same as the Ponseti technique, just you're putting your pressure points in the opposite position. And so really reverse casting this foot to make it almost look, doesn't it almost look like a club foot? So you're trying to almost create a club foot. And then you do a tiny surgery to make sure that those joints are adequately aligned, along with a tiny surgery to release the heel cord. And then you are in a cast for probably about 6 weeks. Bracing in this foot deformity, while sometimes the surgery is a bit more involved than the initial surgery for a clubfoot, the bracing can be a little simpler and sometimes not as long-standing as kids with club feet. Yes. If they had a congenital vertical talus. Yeah, and so sometimes they may need bracing for upstream reasons too. Like for instance, if they had a weaker quadricep or a knee flexion contracture, their foot might be great, but they may need that extra support to kind of help help just the upstream effects or weaknesses. So yeah, sometimes. So yeah, but for the purposes of the foot itself, you may not have to have that bracing until skeletal maturity. So what are the outcomes? So most of these studies, to be perfectly honest, have been done more in the idiopathic CVT, so a child who's born with just a congenital vertical talus, and as we know, that doesn't qualify you for arthrogryposis. You have to have involvement in more than one body region. But the summary is that reverse Ponseti method works for initial correction. And then most of these studies had a little bit longer follow-up and seems to have some longer term success too. All right, so let's talk about what happens if you have like a really stubborn congenital vertical talus. Well, then sometimes we need to jump to more of that open procedure where we just physically open that joint and help realign it. Tends to be a little bit bigger incision. But here's a child who you can see that talus is pointing down. The midfoot's basically on top, and now we have a pretty well aligned foot. So just because we have to jump to open surgery doesn't mean anybody failed, just means the foot just needs more. Sometimes we there's just not enough space if the child comes to me a little bit older, like 5 or 6. We've had to a couple of times take one of the bones out in the middle of the foot called the navicular and just create space. And then overall a little bit of sag on that talus. So not like the perfect X-ray, but this child like runs, you would never be able to tell that his foot had was that involved as an infant. And then sometimes like these feet are the sweetest patient, the sweetest girl, but the most awful feet. And I'm just waiting till she tells me like, Doc, I can't do anything. And then we'll probably have to use a fusion strategy. They're just tough feet. So, but we're going to reserve that for hopefully when she's done growing so that we can just be one and done. So let's just summarize. So first 3 to 4 months, whether it's feet, knees, hips, like you're in that golden window where conservative management can work in the form of range of motion and stretching and splinting. And we just we love it when parents come to us young because it really helps us to potentially redirect the trajectory of their life. So a brief story. This is one of my little cuties. His name is Wyatt. He's a twin. And we got to meet him when he was just a little less than 2 months old. But you can see his twin brother over there holding his foot for him. I bet they did that when they were in the womb too. But kind of born in that jackknife position and then pretty significant club feet too. So it's like, man, where do we start? But here he is. He's got his costume on, and you can hardly tell except for that he's got his braces. And then what I love is this mom. She just like he's going to do everything his twin does, and so she gets him out there on the soccer field, and he's there he is doing his soccer shots and out there right there with his twin brother. So really coming to us young can make a big. We can't take away the arthrogryposis. We can't take away the severity that they were born with, but really can make huge gains with early intervention. All right, let's move on to the toddler and preschool years. So infancy seems busy, and it's really busy with a lot of therapy appointments. The toddler preschool years is where you start seeing me a little bit more. It's especially if the stretching, the splinting is not going the way we need it to go, or a child's been, is adopted and coming to us a little bit late or later. It's never too late, but later. And so again, our goal is functional locomotion. This is the time frame where I'm really thinking like these kids are bright. I want to get them in school. I don't want to disrupt their education. We're going to try to knock out most major orthopedic interventions in this time frame. So this is, if you're a parent of a young one and thinking forward, like this is going to be potentially a busy time. And so let's just talk about feet. Hopefully we've gotten some casting and we've got the foot in an improved position and we're just managing either a recurrence or a residual deformity. But then I can't talk about feet without talking about the rest of the lower extremity, so knees and hips. This is a time where if they're really flexed, we're going to try hard to straighten them. If they are extended, we're going to try hard. We'll discuss whether or not to try to get them to bend. And then hips, if there's a dislocated hip, we're going to try to put it back in socket. Or if the hip is stuck in a weird position, we may talk about doing an osteotomy to reorient it. The folks at Nemours, DuPont in Delaware did a good study about casting for recurrence for AMC clubfoot. Because you say like, okay, what's the first line of intervention? Well, if it's just a mild deformity, I think we can cast to try to get the foot into a better braceable position. They had 46 kids. What they found is it was effective in temporarily improving the foot positioning for brace tolerance, and it was like kind of a stepping stone to delaying intervention. So certainly that's something that is my first line of thought if I see a kid in that preschool age range with just a milder recurrence. I'm like, okay, maybe let's see if we can cast this out. But let's talk about surgical options. We'll talk about doing some soft tissue releases and then potentially tendon transfers. So that big surgery, I've learned to just kind of fuzz it out. I don't think any parents want to see big open surgeries, but I think if there is a significant recurrence and the child is approaching walking age, I think that's a good time to like, okay, we need to get this foot flat on the ground. And I like to do that with what I call an a la carte soft tissue release. So it doesn't mean that you're getting everything released at once. It means that, okay, whatever structures are tight, that's what we're going to go after and see if we can either lengthen or release them. And so I try to do that when they're either ready to walk or by 4 years of age. if it doesn't look like this child's going to be a really good ambulator. We tend to try to combine that with other interventions at the same time. So just briefly, just really, again, just releasing the tight structures in the back of the ankle. Most have a satisfactory end result, but it can come with some tendency towards recurrence, as any method that we're going to talk about discusses. So this is a young lady who came who had some casting in its anatomy in infancy, now was walking. And so with the posterior and medial releases, we're able to get that foot. A lot of our AMCers have this really prominent fifth metatarsal, so they tend to walk on the outside part of their foot, which can be really painful. You can see that now we've kind of gotten that nice and leveled out. Things to be aware of with releasing is these big structures. As orthopedists, we really like to just only see muscles and bones, but we live in a world where nerves and blood vessels are also there. And so when I do these releases, I do have some kids that get some nerve pain. I think it's something to be aware of on the front end, because we have to move those things out of the way so we can be safe. And I think that just those nerves sometimes they eventually get better, but sometimes cut out the gate, they're not very happy that they got moved from their home temporarily. Okay, let's talk about tendon transfers. To be honest, like for a tendon transfer to work, the foot has to have enough mobility, and then in the non-AMC world, like that muscle actually has to have like some function to it, some integrity to it for the tendon transfer to work. So this is a young man who had distal arthrogryposis. I moved a muscle called the posterior tibialis over to the front to try to give him a little bit of dorsiflexion. He primarily wears his braces because he's just a lot faster in them, but you can see the before and after of moving that tendon over. So I think there are some limited indications. I'm going to give you a little bit of maybe a teaser might be the right way to say it, is that I'm starting to try to do this in even kids that maybe the tendons don't work as well. So this young man had a 2-stage procedure where we did the releases. I came back 2 weeks later just to have the get an added stretch, and I was like, you know what, let's just try to move that tendon over and see if it holds. And I was really happy that, like, so this is again just the foot, I'm not touching it, but then with the tendon holding the foot there. So I'm really curious, and it's going to be something like this is a procedure that we do in the idiopathic world a lot. About 40% of idiopathic club feet need this tendon moved over, so it's not really been studied too much in the AMC world, but more to come on that. So, but I do think it potentially may help to reduce recurrence just by having that internal tether. So more to come on that. So again, I like to kind of just wrap up every segment with kind of a patient story. So this is a little one who came to us about 18 months, 2 years. She had had some surgery on her knees already, and had that Ponseti method on her feet. But those are some huge wedges. She finally was able to get up and walk, but she was not tolerating her braces really well. So she is one that we did the releases on. And now she's up and very comfortable in her braces. She can actually walk short distances in her short braces too. So just try to give these encouragements for especially parents of younger kids that, like, we stick with it. Usually these kids are overcomers in the best sense. Okay, let's talk about school age. As I hinted before, most of these kids are super smart, and we want to try to minimize our disruptions to school. And so hopefully, honestly, we're in a maintenance phase. Hopefully we've gotten those big, scary interventions out of the way when they are in that toddler preschool time frame. But occasionally we get kids that have grown up in an orphanage overseas, and they're just now coming to us in their third grade. And so this is where kind of the age group that's 6 and up, where I feel, again, there's different, and that's why I think it's so great that we get physicians from different hospitals, different contexts, because everybody's kind of approaches it a little differently. And I think you as parents and families just have to decide, like, that approach resounds with me. But I say after about 6, I'm certainly willing to try casting if a family comes to me. But I usually tell them, I like to feel the foot. The foot has mobility. I think casting may have a role. But if that foot feels like a piece of concrete, I'm like, I just don't know that casting is going to get us what we want without a lot of skin issues. And so this might be an age group where we can discuss potentially trying some casting. Whatever give we get from the soft tissue is great, but we may need to lean more on a surgical strategy. So it's still a busy time with spending a lot, with bracing and night splints. But this is where we're going to start throwing in maybe some bony surgeries. And there's a lot of overlap. Just because your child is 8 doesn't mean they can't have a tendon transfer. I'm just trying to throw in all kind of make sure I cover all of the surgical options out there. There's a lot of tools in the toolbox. Let's talk about kind of a word that maybe has a dirty taste in the AMC community, but talectomy. Again, think like this is an 8 or 9-year-old child coming. They have terrible club feet, but maybe they're really good upstream of that. This might be an option that we use. So what does that mean? So the talus bone is this bone in the middle of the ankle. And this is a little bit like older school procedure, but sometimes we'll take that talus bone out. Sometimes the foot is really, remember that adductus, that kidney bean position. Sometimes we need to accompany that with taking a little bit of bone out of the side here too to really swing that foot over. So this is some honestly pictures from a textbook, but just showing what improvement we can get. We went from like a foot in severe equinus, but postoperatively have that foot in a plantigrade position. This is a young lady who was 13, 14, and she had oodles of casting prior to, and so I took her talus out, and again a more plantigrade foot, certainly not perfect. But let's see what the literature shows. It does show that a lot of these kids get spontaneous fusion between that heel bone and the talus or and the tibia bone. I think there's different feelings towards that. If the foot is overall really stiff and then it's fused in a good position, that might not be a bad thing. If the child's already wearing braces and that brace doesn't really move, that might be a bad thing. It would be a bad thing though if this child otherwise has like great mobility and their foot had good mobility. Yeah, then that's not a good outcome. So again, I think you can't look at this X-ray and say that's a great outcome without seeing the rest of the patient. Okay, so then a procedure that I just always want to be forthright. I've been doing for about 18 months to 2 years now. Again, was described in the 90s, the Verabelli Ogston procedure. Again, after about 6, I think the foot is a little too stiff to really be responsive to casting. I think it becomes a bone problem. Let's back the train up. Why does Ponseti casting work in the infant to begin with? Well, when babies are born, most of their bones are actually not ossified or calcified yet. Most of their bones are made of cartilage, and cartilage has a lot more give, is a little bit more like clay than a bone. A bone, everybody's had a chicken wing, or maybe if you're a vegetarian, I'm not sure, but you know what I'm talking about. A bone, you're not gonna be able to push. If you push too much, then it breaks. Cartilage is again a little bit more like a thicker clay, and so those baby feet that come to us, we can reshape those bones that are not yet ossified through that casting process. Again, I think that tide sort of turns between ages like 4 to 8, so that's why I just say 6 in the middle, to where now it's not just a bunch of cartilage, you have a lot of bone. And so this young man had already had the release. His foot is really not too bad. I'm going to show a video of him in just a second, but he still couldn't get his heel on the ground. I did have to do some upstream work. If you can imagine, if your knee is bent, it's going to be really hard to get your heel down, even if you have good range of motion. So again, we look at the whole child. But what is this procedure? So it's where I go in and I make a little small window in the talus. I kind of take out the bone that's on the inside, so not the shell. I leave all of the articular surfaces, and then I just take out the bone that's on the inside. And then I just do a Ponseti maneuver, basically in the operating room, child's asleep. And then I'm able to bring the foot and reshape that bone, so it kind of reshapes that talus into a more functional position. I'd say, this is the 7-year-old that had it. But here's his before and after. Let's see if we can get this to roll. There we go. Okay. And so, yeah, again, pre-op, he was really up on his toes and on that lateral aspect of the foot. which you can imagine just not very comfortable. For anybody with typical feet, I challenge you to even walk to the wall just on that outside part of your foot. Oh, it hurts. And so did the Taylor decancellation procedure, and now his feet are more flat. Again, full disclosure, I had to work upstream. He had a bit of a knee flexion contracture as well. And so you can't just work on just the feet and expect the feet to be flat. You got to look at the whole kinetic chain. So what are the outcomes on that? They're mostly smaller studies, but showed pretty good outcomes. For like 75 to 80% of kids did really well. I think what my challenge is I need to follow these kids. I'm not offering it like candy, like, oh yeah, let's just sign all everybody up. And so I think now that I'm getting kind of my 1 year to 18-month follow-up, and I'm seeing like, I think this is working well. I think there's gonna be, again, kind of with the tendon transfers, there's gonna be more to come. The procedure makes sense. It's my job to follow these kids, make sure that they have a good outcome before we kind of offer it more broadly. So okay, and then let's land the plane for any skeleton mature or adults in the rooms, or friends of adults with arthrogryposis. Again, a theme similar to our school age children, that we're just going to correct any residual deformities that are creating pain or inhibiting potential function. Sometimes we can do something. Sometimes we operate on children or young folks. Sometimes we can just operate on shoes. I like to remind families of that. Like, yeah, those are not like the most fun shoes to maybe go to high school in, but if a child's looking at me and they're like, really, if you just give me like a nice comfortable shoe, I can do this. And it's like, man, that's a lot easier on you and on me than offering you a big surgery. So let's talk about our surgical options too for this age group. We'll talk about external fixation, a midfoot osteotomy, and then arthrodesis, and the dreaded A word that Rini talked about in the last lecture. So external fixator, this is some of you may have experienced this for your knees, but it's a similar concept that you can have for your feet as well, where these wires and pins are placed into the bones, and then they're connected to a frame. Usually in today's age, we program that through a computer, and the computer tells you where to twist and turn on a daily basis, and gradually the foot is brought into that plantigrade position. And so it can be combined with some osteotomies to kind of get more of that faster correction. And many people do have good results, at least with regards to getting the foot flat. I will say that slow stretch along the way sometimes can really irritate the nerves, and sometimes can create a pretty sensitive foot. So certainly not the panacea, but a tool in our toolbox. The midfoot osteotomy is one I tend to lean on in these more skeletally mature kids. Again, it's really hard to walk on the base of your fifth metatarsal. That hurts over time. And so we can do a midfoot osteotomy. This young lady needs to rotate her shin bone as well. This is a piece of information we look at when we get our gait study. It's called a foot pressure, or the fancy word is a pedobarograph. And as you can see, the red hot spots of where she was walking beforehand, and now the pressure is a little bit more evenly distributed. We actually don't have any pink on either of the feet. And a bit, there we go. And let's see. Not too bad for a whole presentation. The clicker just misbehaved. But the before and after, you can see how the feet are pretty rotated in. She's really walking on the outside part of the foot, and now the feet are much more plantigrade. So pretty powerful. I will say not easy. The surgery is not terribly complex. Not easy. Nobody has fun when you cut the bones in your foot. Let's just be honest. That really hurts. And it's a bit of a commitment as far as recovery. But if your bad days are outnumbering your good days, it's time to do something. And then let's talk about arthrodesis. That's just a fancy word for meaning that we're fusing the joints together. Let me just say that a lot of our, maybe not a lot, but a good many of our AMCers that come to me older, sometimes they'll come to me and they'll ask to be casted, but I take an X-ray of their feet. And I'm like, well, I hate to break it to you, but your foot's kind of already fused. Like the bones are kind of already auto-fused. I probably just a process of not moving the joints in a typical way or always being in a brace. That sometimes the body's like, oh, that joint, you're not using me as a joint. So if you're not using me as a joint, I may as well no longer be a joint. But sometimes that happens. So this young man basically had like an auto fusion of his ankle already. Like you really can't see that clear space that you kind of see right there. But it was in a, he's got about almost 40 degrees of equinus, so he's always walking up on his toes. So once the joint is pretty much fused, unless you do a joint replacement surgery, there's no joint recreation surgery. There's like joint reconstructions, but I can't create cartilage where the cartilage has already decided that it's served its purpose and it's not there. So this young man, we did an ankle fusion just to get the foot flat beneath him, and he was very happy. There's a video of him beforehand, just on that right side. Unfortunately, he did not come back for follow-up. I talked with him over video, but I don't have a post-op video for him. But so again, it can be pretty powerful just to reorient the direction of the foot. And then let's talk about the dreaded A word just briefly. I think everybody just deserves to know all of the tools in the toolbox. As Rini said, this is kind of a strategy of last resort. I honestly don't really offer this unless a child comes to me and says, Doc, like, I'm done. Can we just talk about this? That's usually when I'm having that conversation. I will say, in Reni's talk, if you didn't get to listen to it, I think there'll be a recording on Facebook. But for me, what I love to see is that the kid has good arms, so they can already don and off their braces by themselves. That's usually a good indicator that they're going to be able to put their prosthetic on and off well. And then I love to see good hip extensors. That means that they're going to be able to power those prosthetics and do well. But certainly, if the goal is mobilization, the kids had multiple surgeries. They're like, I want one surgery and be done. And usually these kids are coming to me in their adolescent years and saying, the ones that I have done, that it's something like I usually make them go away for a long time and go do other things. And then if they still come back and say, yeah, I want this done, then we'll go for it. But so this young lady has a very vivacious personality. Disclosure: I didn't do her surgery. There's somebody closer to home that was very capable. She just came to me and she was just like, I just need somebody to make sure that this is a good idea. This is an appropriate idea. But I couldn't even get a video of her walking barefoot because she hurt so bad. She had such a bad. She's a very good walker, but she had such a bad callus here. She couldn't even walk barefoot. And she's like, I would just rather take this part off. And so here she is post-op. That's kind of what she had. What's called a Symes or an ankle disarticulation, where they just took below the ankle. Here's her early, and then this is, I think, about 6 months, and she is pounding away. Again, very vivacious personality here. So I would not probably tell her what to do in life. Then one more young man, just to kind of as an example of maybe somebody who had a little bit higher level amputation. So this young man, again, really good arms. That takes a ton of strength to support your legs on those loft string crutches. So you can tell he's really strong in his arms. But he told me, he's like, Doc, I've never been able to throw a football without having to lean on something, because he always had to have his crutches. And so again, I sent him away. We waited probably almost a year before we decided to go forward. And then this is him early on. We tend to start with a pretty basic prosthetic and then grow into the more complex. But he just came back for his 1-year follow-up. This is him in his full prosthetics, and I would say, put a pair of pants on that young man and you're not going to be able to tell. So amputation is not for everybody. I love what she says, that if you can walk without pain, keep your foot. But if it gets worse and worse and keeps you from doing what you love, cut it off. It'll be hard and you'll get a lot of TV time, but with determination and hard work, you can walk again without pain. Don't get discouraged. So that's a young lady. So my encouragement, I'm not trying to sell amputation by any means. Again, it's a strategy of last resort. But I think as an AMC community, we are so inclusive of each other's abilities. We also need to be accepting and inclusive of people's treatment decisions, and just recognize they probably, of anybody, put a lot of hard thought into it. And so that's just my encouragement is don't judge anybody's decisions on how to treat their child. That's really a pretty personal and individualized decision. But these are all tools in the toolbox. That was a lot. You guys constantly have me thinking all the time. I'm usually tired by the end of clinic, so I'm like, that was a lot of thinking, trying to figure out, what to do, when to do it. But just things to keep in remember, like we really try to keep a holistic view of the patient. Sometimes I'm like, this surgery needs to happen, but they're not mentally ready. It means we need to wait. We need everybody to be as on board as possible. It's kind of like having a baby. You're never going to be fully ready, but we got to, there's optimal timings. And then I really emphasize shared decision making. My families will say, like, I say a lot, I'm like, I'll make recommendations, but we make decisions. I can't just say, this is what you need to do. We have to make the decision. And then increasingly that becomes the person whose body that we're talking about becomes their decision. And that tends to happen around 10, but just given different levels of maturity and a mental awareness, that's flexible. But I do usually around age 10 start to look at the kid and like, okay, this is your life and your body. Like you tell me. And I think that's good practice for them as they grow into adults. So this is a journey. We're on this together. What I can promise is that we had just a wonderful team. It's not just me. I know everybody's like, somebody saw me in the elevator, like, oh, the famous Dr. Hyer. I'm like, maybe like we have such a great team, and that's what I really want to hammer home, is that it's not just me. Again, if it was just me, that stool would topple over. I really have wonderful rehab and prosthetic and orthotic support to help keep our mission going. Which our mission at Greenville is doing the right thing the right way every time for every child. So I want to open up to any questions, and I want to just say thank you.